excited to get to talk with those of you present today, as well as talking to anyone who is joining in the future. We are recording this presentation. I want to thank Christy and Elsa for the invitation to talk. It's always a really distinct pleasure to be able to bring my my expertise forward in a very direct manner to families and patients, and outside of the clinic setting, where I feel like sometimes we can get a little more in depth about things, and that's exactly what I'm planning to do. My name is Molly Knigge. I am a speech language pathologist, and so I wanted to explain that when we say SLP, that's what we are referring to. But I have a specialty designation in swallowing, and that is the board certified specialist in swallowing, the BCS-S at the end of my name. Not every speech pathologist is going to have that designation, nor do they need to. But when we do, that is just one way for the consumer to know that we are practicing at a more advanced level, at least one that's been recognized by our own discipline. And so in the case of ALS or PLS or PMA or all of the motor neuron disease categories, certainly looking for the BCS-S designation is something that you can do if you're looking for someone who is more of a very specific specialist in swallowing. So I wanted to go through some of the underlying mechanisms that exist in motor neuron disease. And I'm not just saying ALS. I suspect all of you are pretty used to this now. It's sort of a shift going on in talking about this category of motor neuron disease because there are a lot of similarities amongst the different disease types. And I'm going to describe the dysphagia or the swallowing difficulty that exists in these different subtypes. We'll talk a little bit about swallowing evaluations and then ultimately about treatment options. And with all of this, I'm hoping to kind of carry you through the process, demystify our evaluations a little bit so that you can understand why we do all of these things that we do in clinic. Complicated slide, but the brain is complicated, isn't it? And so is the nervous system. And so what I'm really going to talk a little bit about first is what do we mean by motor neurons and motor neuron disease?
Hey,
and
Mom, I'm sorry, I don't think it's switched to the slide. We're just seeing the first one still.
Oh, well, is it switching now?
No.
Well, that's interesting. Let me come out.
Now it just switched to the goals.
Yeah, and I'm going to just do from beginning and maybe it will come with me. Is it switching now?
No.
Nothing. Why is it not switching?
Yeah, maybe if you just, oh, there, now it's on slide 4, looks like.
Yeah, but you're seeing my whole thing, not the slideshow, right?
Right, yep.
It seems like every time I go into slideshow, let me just see if I use a different button. Let me try that once. What about this?
No. What if you hit the down arrow?
How about that?
Nope.
None of the different buttons are working. I've done space bars. I've done arrows. Those are.
Have you started the presentation?
Yeah, that's what I'm in right now is slideshow.
Okay, right now all we're seeing is the.
Yeah, once I go out here, it seems like it's working. So I apologize, Christy. I'm going to have to do it in this mode, I guess.
Oh yeah, that's okay. And just so you know, I'll cut this out of the recording. So.
Okay, thank you. All right. So thanks, you guys, yeah. So the goals, did you get that part?
Yes.
Yeah, I think we're good on that.
So then, so this slide is the complicated one I was talking about. And in thinking about the brain and the motor system, what I'm going to talk about is what upper motor neuron and lower motor neuron means when we're talking about speech and swallowing. And specifically swallowing, but speech and swallowing share musculature and share a nervous system. That's why speech language pathologists work with swallowing as well. So when we're hearing the neurologists often, we'll talk about upper motor neuron or lower motor neuron. What we're really talking about are two different levels of the nervous system that can be affected by these disease processes. And so the upper motor neuron system are the motor nerves where the cell bodies lie within the motor cortex, so a part of the brain that is designed to control movement and help you as it carries out some of the programs. And so those axons, these nerves that start in that particular area, then reach down through this tract called the corticobulbar tract, and they then end in the brainstem, which is where speech and swallowing is going to be directed from. You'll notice that I'm just talking about speech and swallowing, and that is because things like the upper extremities and lower extremities are then going to go down through the spinal cord. Speech and swallowing do not go through the spinal cord. They come through the nerves that then begin in the brainstem out to the muscles, and that's the lower motor neuron system. And so these motor neurons are inside the brainstem motor nuclei, and then they go directly out to what we call the bulbar muscles. Whenever you hear that word bulbar, we're really talking about this lower motor neuron system and those nerves that go out to the facial muscles, the muscles of the mouth, the muscles of the throat, and the muscles of the respiratory system. And when we think about the effects of disease in the upper motor neuron and lower motor neuron systems, there are some differences. And so these are some of the things that we're really looking for when patients are coming into clinic and we start taking a look at some of the different movements. In the upper motor neuron category, we're often looking at effects that involve the tone of the muscles, and particularly too much tone. So there's increased muscle tone and slowed movement that results. There's also another problem that can arise called hyperreflexia. And just generally knowing that these are some overactive reflex responses that can happen in muscles. But there's one specifically in the speech and breathing mechanism that I'll talk about today called laryngospasm. Then if we think about the lower motor neuron system, this is where we're really looking more at things like strength. So muscle mass can be affected, and there can be a loss of muscle mass. In the speech and swallowing system, we're particularly able to see this in the tongue. There's another phenomenon called fasciculations. What these are twitching of the muscle that happens when the nerve signals are interrupted by the disease process. And again, we can see this in the tongue. Sometimes I'll see them even in the face muscles, like in the chin or something that can be evident as well. And certainly fasciculations can happen in the muscles and the extremities as well. So sometimes people might notice those first in the arms or in the legs. And then finally, as I mentioned, this really does relate to strength. And so instead of muscle tone, which is the upper motor neurons, the lower motor neurons are going to have much more to do with the strength of the muscle itself and the muscle's ability to contract or produce a force as it is with swallowing. I do, as a speech language pathologist, want to talk very quickly about speech, because speech, as a swallowing specialist, speech is one of the things that really helps me as I'm getting to meet someone for the first time and getting to understand what their muscles and nervous system are going through. Listening to speech becomes a very important clue for me. And so what we do encounter in upper motor neuron and lower motor neuron disease is something called dysarthria. Now, dysarthria can happen in really any kind of neurologic condition or disease process. But specifically in motor neuron disease, we're really going to be listening for things like changes in the speech sounds. And so this isn't so much difficulty finding words or, being able to remember things. Those are different kinds of brain and speech and language types of functions. But we're going to be mostly interested in articulation, whether the person is able to be understood or if it's becoming more difficult to understand their speech. It may be from the patient's perspective that it just takes more effort for them to be understood or to be able to change their speech so that people can understand them better. And finally, there can be in the more advanced stages of diseases, loss of speech ability, in which case then that tends to take us into a different kind of specialty in speech language pathology where systems for augmentative and alternative communication can be looked at for helping patients to communicate. So for our purposes today, we're really going to be talking a little bit more about verbal communication and using the body to make those sounds. And so we'll talk a little bit more about this because I think because speech is something that we can hear and we can watch and we can listen, it can be very much easier to understand what the muscles are actually going through. And so we have two different types of dysarthria. And this really is purely explaining what happens to the muscle itself. And one is flaccidity or a flaccid dysarthria. The other is spasticity. And so again, the spasticity, I'll start with that one on the bottom because it was the order we went in earlier, is the upper motor neuron effects on speech. And that can result in some slower speaking rate. And so patients might hear themselves straining or having a harsher voice coming out when they're talking. It can result in some pitch breaks in the voice and slowed but regular sounds. And so often I like to listen to patients as they're in connected speech and listen for how the sounds are kind of connecting to each other. And is there a nice rhythm to that? For example, if we say something like, I like this one because it's a really tough one to articulate, Methodist Episcopal. That is a very complex set of sounds to be able to articulate. And certainly when we are saying that, we don't say Methodist Episcopal. That's equal and too much stress on each syllable. But instead, we kind of go with a rhythm, Methodist Episcopal. And there are syllables that are more emphasized and others that are less emphasized. Ultimately, that rhythm is just part of what our muscle tone actually contributes to. And so some of these very fine aspects of communication can give us some idea and actually a very early idea of what muscles might be encountering. And ultimately, what goes with that spasticity is some of the other aspects of motor neuron disease, the upper motor neurons, as I was mentioning, the overactive reflexes. Some patients with upper motor neuron disease may have an ease of laughing or crying. And that is called a pseudobulbar affect. Too much of the tone in the muscles is really what we're talking about when we're talking about spasticity. There can be some hyperactive reflexes like gagging reflex. And then also the voice box can go into a reflex called a laryngospasm. And I like to make sure that I mention this to people because occasionally patients who have ALS or who have PLS, both of those are motor neuron diseases where the upper motor neurons can be affected, might run into some of these breathing episodes. And it can be very frustrating because we don't really talk about it too much until someone says, I choked on my spit, or I choke when I laugh. And family members can become very, very concerned about these because it does look exactly like someone is choking because the voice box reacts and it's overreactive. If a little bit of spit goes in there, or if the person's laughing and for whatever reason just triggers this reflex, it can result in some people going into a breathing episode where they're really having to work harder to get their breath. They might have what's called stridor, kind of pulling that air through a voice box that's kind of trying to be overprotective. What we like to tell people about these is that first of all, they do relax over a very long minute or so. But there is also something that can be done about them, and that is to try taking some sniffs in. Initially, it can be hard when the voice box kind of squeezes up on people, but taking some rapid sniffs, trying to get the air in and pulling those vocal cords back open can then override the spasm. It overrides the reflex. And just trying to get the word out to anybody who might be noticing some of these spasms, by all means, get in touch with your neurologist, have them get in touch with the speech pathologist that you're working with. And it's something that those of us in swallowing and also in the voice specialty are very, very familiar with and can talk with you more about how to get out of them when they start. And then sometimes we can even have you prevent them if you're worried about one starting. We can do that too. So just for folks to know what those are. And certainly if you've got questions about those, I'm very happy to talk about that. On the other hand, we've got the lower motor neuron, flaccidity, speech sounds. This can lead to a breathy voice, more of that kind of weak voice, weak speech. Diplophobia just means that there are two different sounds that come out at the same time. And so it's a very hoarse and kind of complicated sound that comes out that can be harder to understand. There can be audible inspiration or stridor with this, nasal air emissions where people are talking and the sound is kind of coming out of their nose. That is one of the valves that has to work well when we're talking, is the palate and the back of the mouth. And if it's not working as well, if there's some weakness in it, some of that air can come through the nose and make it harder to understand sounds like the p sound in puppy. Short phrases might have less breath support. This is where breathing can become weaker for individuals where the diaphragm and the breathing muscles are affected. And lastly, the imprecise but regular sounds. So for example, with the p sound, it might just be a weaker p. That can be harder to pop out. It might have less breath support. There are a lot of aspects of strength that can certainly affect talking. And just a couple of other physical characteristics that go with that lower motor neuron, more weakness side of things, is that loss of tongue muscle mass, the twitching muscles. On this side of it, you can have the loss of a gag reflex. And so it might be that the sensory system is a little too forgiving. And finally, liquids coming out of the nose when swallowing is another feature of that palate as far as how it helps to protect. I wanted to share with you, I had a very kind patient who gave me a recording of his voice as an example of, I'm going to let maybe have a little interaction here, upper motor neuron or lower motor neuron. See what you think, but it's a very good example. If we listen to the speech.
Your goal is pop, 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 pop. Tot, 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 tot. Cut, 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 cut. You wish to know all about my grandfather. Well, he is nearly 93 years old.
I'm going to stop it there. Anybody have any guesses as to whether that would represent weakness, or might it represent a little too much muscle tone and that slowness? This one would be a good example of the slowness. And so when we are hearing things like, you wish to know all about my grandfather, that is representing the slowness that we're really listening for. So from there, we want to think a little bit more about swallowing. What is swallowing? Is a good place to start. And when we're talking about with patients, are you having difficulties with swallowing? It's kind of good for us to define what we mean by that, because it can mean so many different things to different people. Food, liquids, pills, saliva, and secretions are things that need to be swallowed. And this really means the movement of these items from lips to stomach. It could involve the mouth, so oral preparation, being able to chew the foods and move them down back to the throat. That both of those phases are the oral phase of swallowing. And then there's pharyngeal transit, moving the foods from the top of the throat to the bottom of the throat. And then finally, esophageal transit, which is going to be moving the foods from the top of the esophagus down to the stomach. Now, in the midst of thinking about how all of the muscles move through those areas and the sensory system are working together with those muscles, ultimately, we're kind of boiling it down to two things: safety and efficiency. So we want the foods to safely pass from the mouth down to the stomach without entering the airway. That is the wrong pipe. And that, of course, is what can lead to coughing or choking. I think this is one that we very frequently think about when we think of, am I swallowing okay? But there's also efficiency, and that can involve anything from chewing efficiently down to getting the foods through your esophagus efficiently. But really, for the purposes of our talk today, we're going to be talking about the mouth and throat, not so much about the esophagus. But we always have to recognize that individuals with motor neuron disease also have other medical things going on. And so we certainly listen to these symptoms that we talk about in clinic and consider whether it might be in some cases that it's something not related to ALS or PLS, for example. Efficiency then can result in things being left behind. And so reduced efficiency in the mouth or throat can result in foods staying in the mouth or staying in the throat, even though the muscles are trying to push it down. And ultimately, feeding behaviors do impact swallowing. And so that's where speech language pathologists really work with both sides of this. When it comes to eating, we're really talking about both feeding and swallowing. However, what we're not dealing with is getting the food from the plate to the mouth. That is going to be an occupational therapy specialty. And so while we watch for that, and certainly in our interdisciplinary work, we do have discussions about how that might be affecting swallowing. For the most part, when it comes to feeding, we're going to be thinking about things like the size of the bite. How quickly are you eating? How quickly are you drinking? Are you drinking from a cup or a straw? So some of these aspects are factors that we can play with a little bit to see if we can impact safety and efficiency for patients, and they're pretty easy ways of us doing that. So ultimately, dysphagia means difficulty swallowing, and so when I'm saying that term, just so that I can bring you guys along in that medical term for swallowing problems. So when we're thinking about dysphagia, there are these subtypes that absolutely kind of make sense when we think about those underlying mechanisms of too much muscle tone or weakness. And so some patients might have more isolated upper motor neuron symptoms, and this might be termed primary lateral sclerosis if the neurologist feels like that's the only thing going on, usually for multiple years, as opposed to isolated lower motor neuron symptoms. That would be primary muscular atrophy. Again, a very different category of disease. But what we have to remember is that really ALS is a mixed upper motor neuron and lower motor neuron disease. And sometimes one of those might start, and then eventually the other symptoms do set in which case then the neurologist will label it ALS. So this is why we like to talk about motor neuron disease, because it really is encompassing more than just ALS. And then I do like to talk a little bit about the fact that there is a type of ALS where there's primarily respiratory symptoms, and how that can impact some of the decisions in swallowing, particularly when it comes to feeding tube placements. Patients might end up pursuing a feeding tube placement early before they're really having that degree of swallowing difficulty, because the doctor feels that they should get it done while they are healthy enough to go through the procedure. And so ultimately, for patients who do have more primary respiratory symptoms, we do like to come in and chat with these patients, not because they are having as many swallowing symptoms, but so that we can help manage some of that decision making as they are up against thinking about a feeding tube placement, if that is in line with their wishes. On the other hand, there is another type of ALS where frontotemporal dementia can come with it, and that I'm going to talk about in a few more slides. But just to point out that that can add kind of a different type of speech language pathology approach for us, because some of the aspects of the brain for regulating how quickly we eat, regulating some of the feeding behaviors, regulating the size of the bites can really be affected more in the case of something like dementia. So when you are coming into clinic, the speech language pathologist needs to bring their A game in both speech and swallowing. And I just wanted to share with you some of the things that we do during our, what we call a clinical evaluation. When we're just in the room with you, we don't have necessarily any X-ray equipment with us or any scoping equipment with us, but rather our eyes and our ears and our patient and their families. And so we are going to talk with you probably at length about dietary and oral intake. Dietary really referring more to the textures in your diet, not so much for us the specific things that you're eating. Certainly the dietitian will chat with you about that, but we're really more interested in, are there any liquids that are more difficult for you? Are there any solids that are more difficult for you? Are pills going okay? So kind of breaking down some of these different categories of foods and seeing what your experience is as you're eating meals. We like to hear how your respiratory system and your cough is doing, because that ends up being really important on the protective side and the safety side of swallowing. Likewise, just your overall physiologic capacity. If you're coming in, in a wheelchair and it's difficult to hold your head up, that starts to give us some clues about some of the things that might be really challenging you when you're trying to sit at the table and eat, as opposed to somebody who's maybe walking around and has, perhaps more mobility and capacity for maintaining posture, that might lead us down a different pathway for some ways of managing swallowing. And so those types of observations end up being really important for us too. Swallowing safety evaluation often will bring out some foods, some liquids, and have you show us how you're doing. I really like to usually do some water and a cookie, maybe some applesauce, something that's kind of in between and easy. And then we also like to have you give us a little info on your experience with eating, which I'll show you in a few slides. We do an oral sensory motor exam, which is kind of similar to what the neurologist might put you through. And then finally, paying attention to your respiratory function ends up being important too, as far as your overall fatigue during the day. Do you tend to get tired out? Things like that. So kind of going back to a few of these things, when we're looking at the oral mechanism and the throat, things that we're looking for are symmetry and how your muscles are looking, how your palate is looking. When you're breathing at rest, does it look like, it's really comfortable for you? Do you look like you've got some higher rates of breathing? Are there any lesions or irritations or scars of prior surgeries? All of that information ultimately is important in your overall swallowing status, whether you've had any trauma in the past, and certainly your dental status. I think people often underestimate the importance of having a full set of teeth for chewing, or the difference between having dentures and having your own teeth can also be a very big difference. So we do like to promote thinking about what your capabilities are with various dental status. Range of movement, we'll ask you to move things back and forth, side to side, up and down. And this is really to see the distance that you're able to move the muscles and how also how rapidly you're able to do that. Strength, we really love to measure. And I brought by an IOP here just to show you that this device, very portable, easy for us to bring over to clinic. And it's one where you just place it in your mouth, and I can do a peak measure with patients. I got up to a 67, and that is more than normal for my age group. I definitely need to be above 40. So that's not too bad, 67. And we can take a look at the front of the tongue, the middle of the tongue when we're doing that one. And I'll talk about that one again in a few slides here, but it's a really easy one for us to measure. And also some subjective observations with strength. Can we move your lips or your jaws apart? Does the tongue resist when we're pushing against your cheek? Does the palate allow you to puff out your cheeks? Things like that. Speed of movement, as I mentioned, with the upper motor neuron disease component, that muscle tone is important for us to assess. And so that's really what we're listening for. If we have people say, pa, 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 is it quick, or does it have to be slowed down? Pa, 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 pa. Slowed voice box movements. Now, sometimes you can hear this in laughing. And so, for example, the patient themselves or the family members may hear that. But the way I usually listen to it is just by having someone say, e, e, e. And we want to hear the vocal cords coming together nice and fast. And then buttercup 3 times really fast. Buttercup, buttercup, buttercup. That is also going to give us a good sense of how quickly those muscles can move back and forth. Even if they can't move quickly, are they able to still be nice and precise? And so even if it's pa, 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 if it can't be fast, is it still able to achieve a good precise movement? Sensation, extremely important with swallowing. I like to tell people, think about when we swallow something, lightning fast analysis going on as we are chewing and swallowing foods. Taste is another one that it amazes me how many patients do have changes in their taste, even though we really focus on the motor and muscle aspects of these motor neurons. The reality is there are still some sensory things that happen as well. There can be some dry mouth, which is really interesting. You can have dry mouth from other medications, certainly as well. Often as our patients are getting over 60, 70 years of age, there might be some of that dry mouth just as part of the aging process. But we do have folks also who are on BiPAP, for example, and they might have some drying symptoms too. Drooling or coughing on saliva, we like to make sure we stay on top of that, talking with you about that, making sure you are talking with your neurologist. The neurologists I work with always beat me to it, and they're amazing, but we always want to make sure that if saliva is bothering you, to encourage you to talk with the neurologist and whether there might be some medications to help manage that. And then shortness of breath, as we had talked earlier about respiration, and then those breathing episodes, those spasms, definitely chat with us about those. I had mentioned frontotemporal dementia, and this can show up in some different ways, certainly memory impairments. It can show up with difficulties kind of organizing oneself, or different behaviors like impulsivity can happen. And so when it comes to feeding and swallowing, some of these executive functions, the ability to monitor yourself and how fast you're eating and how big the bites are, all of those little things we do while we're eating to make sure that we're safe can then require someone else do some assisting to make sure that that stays safe for the family member. And so that's something that is also really important to talk about. It can be one that's kind of scary to talk about, and I think we have to acknowledge that that there still is very much a stigma associated with dementia. But ultimately in the clinic, the thing that is the most helpful to us is to know what, when we're evaluating a patient, all of these different factors that fit into how we can help you. And so I really like to encourage just being honest, being really open about it. Ultimately, you still have the choice as to whether you're going to buy what we have to say, but it really is very helpful to have that kind of that open, honest conversation about some of these things that can be pretty hard to talk about. And this was just a few scientific slides I wanted to throw in there just to say that when it comes to tongue speed and strength and range of movement, it really does matter when it comes to swallowing. It isn't just something that we're super into as speech language pathologists, which, you know, I guess some people are, but it definitely comes down to measuring how the tongue is functioning for swallowing. And so these are just a couple of different things that speech pathologists work with. And particularly this bottom one here is talking about aspiration or material going into the lungs when swallowing. Speed has most to do with liquid. If you think about it, water pours really fast. Applesauce does not. And so speed, or the upper motor neuron type of motor difficulty, can really affect how you drink. As opposed to things like applesauce, you have to have more strength to push that thicker material down. And then certainly if they had solids on here, that would be even more true. And so just some things to think about when we're thinking about foods and what might be causing some of that difficulty. The E10, some of you patients have run into this questionnaire, and I thank you for filling it out whenever we're sending it across my chart. But it truly is very helpful for us to know what your perspective on eating is, and that's really what this is about. This is just an example of a worksheet that we actually use in the clinic with the E10 on it, the interviewing questions that we go through, and then some of our oral mechanism examination observations. And of course, we've got strength on there and all of these scientific pieces, this is what we call our evidence base, is what helps to guide us as we do some problem solving with you. The interdisciplinary clinic is incredibly important to us as we are trying to think about the whole patient and not just thinking about our little silo in speech or swallowing. And so I like to encourage folks, if you have the opportunity to participate in an interdisciplinary ALS clinic, this really is designed to be a one-stop shop for as many of these different aspects of upper motor neuron and lower motor neuron disease that you can get from a group of specialists who are familiar with it. That is an important concept. Not all speech language pathologists are going to be familiar with motor neuron disease or ALS, and it's important to check that whoever you are seeing feels like they understand these underlying mechanisms. And I just wanted to throw out some of the ways that we're treating swallowing difficulties before I open this up to questions. And one of those categories, as we talked about slower swallowing or the upper motor neuron features, the slower pace of chewing. If patients try to go too fast and their jaw can't keep up, well, first of all, you could end up biting your tongue or biting your cheek. And so that's where actually purposefully slowing the pace that you are trying, like intentionally trying to chew, can help your tongue to stay out of the way and your cheeks to stay out of the way of those jaws. Because I find that sometimes the jaws can move a little faster than the tongue or the cheeks, and that's usually what happens. And it can be very painful. Single sips at a time is just a way of pacing the liquids. Chin tucks are sometimes effective for slowing the liquid as it's going up over the tongue so that it's not entering the throat quite so quickly. Again, we're looking for a fast response, but when those muscles are moving slower in upper motor neuron disease, we then need to find a way to slow that water down so that we can match the mechanism with what you're trying to swallow. And so that's actually a nice one to play around with. It doesn't always work for everyone, but I would say almost everyone tends to benefit when it comes to those upper motor neuron symptoms. Controlled swallows is just a way of holding a swallow before you intentionally swallow it, just a different way of slowing things down or pacing yourself. A lot of times people will ask, well, what about thicker liquids? We have to be really careful when we're thinking about thickened liquids. And while it is something that can slow the liquid down, it really is a last resort because it does have a really big impact on quality of life. The other thing that we're starting to recognize is that thicker liquids, if they are also going down the wrong pipe, thicker liquids might be worse than thin liquids. And so we really have to think also about the risk of taking thicker liquids. If it doesn't matter what you're drinking and it's going to go down the wrong pipe, we would probably rather have someone doing the thin liquids because it's easier for your respiratory system to move that up and out. And there's quite a bit of research going on in that right now. Weaker swallowing, then patients tend to go to the softer foods, things that are moister, things that are broken down into smaller pieces, so there's less chewing. Blenderizing solids is really when there isn't the capability for really breaking the foods down, but patients are still able to push that food back and swallow, and that's another way that we can compensate for that. Smaller volume sips, smaller volume bites tends to work better with weakness. Not always, but sometimes. Alternating liquids and solids can help to push residue through if it's not all moving down with one or two swallows. Adding moisture to foods also helps it to slide through. Multiple swallows to clear. There are head postures like the chin down posture. There are some turning postures that we might have you try as well. And then finally, I wanted to show everyone that I have had a few patients where when the tongue isn't working as well for being able to drink from a cup or when the lips are becoming weak, sometimes using these squeeze bottles can be helpful to get by. And finally, what about swallowing exercise? This is a really tough question for us right now. But the evidence reviews that have been done are recognizing that there is a bit of support for the idea of exercise, that it can be safe and it can be well tolerated by patients, but we really have to select those patients carefully. And that if we introduce those exercises relatively early on, and I will emphasize, have somebody who's really motivated to do it every day, then there might be a benefit to doing that for quality of life and prolonging function. But the problem is we don't know enough about what is optimal, what are the right exercises to do, how do we improve spasticity? Muscle tone is something that is much more difficult to get at as opposed to weakness. And what is the optimal dosage and the load for exercise training? We are very, very early in any of our exercise research for understanding some of this. So it's not just ALS. And where is the threshold for doing harm instead of good? Because that's really the concern in ALS, because there are muscles that may be so weak that there is no potential for strengthening. And in fact, we could make those muscles work worse for whatever your next meal is. So important things to think about, but I really do like to bring forward the ideas of lingual resistance training if patients are interested in doing some tongue exercises. There are some simple tongue exercises with some load that you can do. There is an expiratory trainer that we'll recommend for some individuals who might need to try to maximize pharyngeal strength. The traditional swallowing exercises, I'm going to be honest, I really don't have a lot of faith in these exercises when it comes to ALS, because they just don't have feedback or a load of exercise to give you. And so really what you put into it is what you get out of it. And I think in ALS, that's a really difficult thing, is to sometimes put enough effort into that to meet an exercise need. So these first two are two that I've been kind of toying with in the past couple of years and talking with some selected patients about. That is what I have for you as far as my talk today. And I assume we'll maybe talk a little bit about feeding tubes as we have questions. And if nobody has questions, I will do a little more talking about that topic. But anybody have